Thank you for joining us today for the 5th Annual Policy Summit presented by the American Association of Kidney Patients. This year's summit is titled Patient Voice, Patient Choice, New Determinants for Kidney Policy. My name is Ed Hickey. I'm president of AAKP and serve as the chair of the Veterans Health Initiative. Professionally, I'm a veteran United States Marine Corps infantry officer. My public service career includes posts on Capitol Hill as an administrative assistant to a United States Congressman and a special assistant at the United States Department of Congress under George H.W. Bush. Following the terror attacks of September 11th, I also served as a senior advisor for Homeland Security for the Director of the United States Civil Service under President George W. Bush. Currently, I'm a practicing attorney in Los Angeles. I'm active in the armed forces legal community, working locally with the Veterans Legal Service Project of the LA County Bar Association to support the legal needs of active military personnel, reservists, and veterans. And at a personal level, I'm a fellow kidney patient. I'm also an experienced caregiver and patient advocate because of the history of kidney disease within my family. I'm pleased to introduce our session titled Critical Barriers to Care Transformation: How Payment Policies Impact Kidney Patient Consumers and Innovation Leaders. AAKP has, for over 50 years, been a champion for patient choice and innovation in kidney medicine, including therapeutics, diagnostics, and devices. That is why AAKP fights for solutions that help diagnose disease earlier, slow disease progression, and helps stop kidney failure. We are strong advocates for preemptive transplantation, greater access to kidney transplants for all patients in need, and home dialysis. AAKP defines high-quality kidney care as timely patient access to therapies that keep patients healthy and fully capable of pursuing their aspirations, such as maintaining a career in meaningful part-time or full-time work, starting a family, owning a home, and retiring securely. After decades of stalemate and little innovation, the kidney community is witnessing a golden era in kidney drug and device development. That is why, in part, AAKP declared the next 10 years is the decade of the kidney. In the past several years, the U.S. Food and Drug Administration has approved several new and safe treatments that help patients better manage kidney diseases and related conditions. AAKP anticipates more approvals in the coming years. These approvals require tremendous research, investment, patient participation in clinical trials, and advocacy. And to be clear, each FDA approval is a significant victory for kidney patients in need and the companies and researchers who have committed themselves to transforming status quo kidney care. Yet these victories are incomplete if patients cannot access the drugs and devices once the FDA has found them to be safe and approved for patient use. Patients, medical professionals in the industry are becoming increasingly frustrated by the cumbersome barriers to patient consumer access to the innovations patients have fought for decades. Some payers, including insurance companies, and at times the Centers for Medicare and Medicaid Services, or CMS, either intentionally or through a lack of understanding of the patient burden of kidney disease, erect barriers to access these FDA-approved treatments. In some cases, some payers do not support these innovations at all. AAKP believes access must be addressed now because access to future innovations will be negatively impacted if we are not successful in these initial fights. Fighting for patient access to new innovations takes courage, political sophistication, and the fortitude to win. This is why AAKP launched its Patient Voice, Patient Choice Initiative in 2022. Through this interactive platform, patients and care partners can quickly identify barriers impacting care, choice, and treatment. Through AAKP, patient consumers can engage elected leaders, government agencies, and payers to raise their voice when timely access to safe, FDA-approved treatments and devices are hindered by nonsensical barriers. Simply put, AAKP is 100% committed to making certain patients receive the right treatment at the right time based on the guidance of the doctors they choose to give them care. Our first speaker is Chris Leibundguth, Director of Federal Government Affairs and Alliance Development for Baxter Healthcare Corporation. AAKP has collaborated closely with Baxter over the past decade on a wide range of issues related to home dialysis and patient access to new technologies that reduce the burdens associated with in-center dialysis care. I'm pleased to say I met Chris during his first week on the job at Baxter, and that his commitment to the principle of patient care choice is nearly unparalleled in the kidney community. Chris, I turn it over to you.
Hello, my name is Chris Leibundguth. I'm the Director of Government Policy and Reimbursement for Baxter. I want to thank AAKP for inviting me to speak at the Policy Summit. Today I'll be talking about shared decision-making, what it is, how it impacts patients who are living with chronic kidney disease, and then some public policy considerations related to shared decision-making. So what is shared decision-making? Shared decision-making is an educational process whereby patient preferences and values are included in decisions about care plans and treatments. The way that those patient preferences are gotten to is by educating the patient about all of the options that are available to them. And then once the patient is fully educated, then their preferences can be utilized effectively in making those decisions. Now, shared decision-making is used in lots of therapeutic areas across healthcare and has been around for quite a while. So then that begs the question, what does shared decision-making mean for patients living with kidney disease? And where that really comes into play is the decisions that are made around when or if a patient's kidneys fail, right? That's really sort of what shared decision-making comes down to for the chronic kidney disease population. And what that ultimately then means is its decisions around modality choice. There are other things that play into shared decision-making, things like education on transplantation and vascular access. But really what this really means is when a patient's kidneys fail, what are those patients' preferences when it comes to whether they dialyze at home or dialyze in a center? Or what are those patients' preferences when it comes to whether they dialyze using hemodialysis or peritoneal dialysis? That's really what shared decision-making means for patients living with chronic kidney disease. And then finally, what does shared decision-making mean when it comes to public policy decisions? This really comes down to reimbursement. Policymakers oftentimes want to incentivize shared decision-making. It's a method for them to really ensure that patient preferences are included in those decisions. And the mechanisms and the levers that they have to incentivize that comes down to things like payment and reimbursement. That's really how they enter into this equation. So in the United States, we actually have a piece of public policy that encapsulates shared decision-making. In 2010, a Medicare benefit was created called the Kidney Disease Education Benefit. And what it does is it reimburses providers for spending time educating patients about modality choice, transplantation, and vascular access, among other topics. Now, what you see here on the slide are two columns. One lists benefits, the other one drawbacks. And I think it's probably wise to think of the benefits as sort of the promise of what the KDE benefit could or should be delivering. On the other side with drawbacks, that's really sort of a lot of the learnings about what the KDE benefit has done over these last 10 years. And so in terms of benefits, what the KDE benefit really does is it promises to do is to facilitate conversations between clinicians, nurses, and CKD patients. That's often, when done correctly, what that means is you have a patient that has informed information and can actively participate in those decisions. And also it becomes a platform for utilizing the latest educational techniques in terms of ensuring those patients can retain action-oriented information. Now, unfortunately, the KDE benefit is very underutilized. And one of the key features of it is that the reimbursement is often judged to be somewhat low. So not sort of the type of reimbursement that's really going to catch the eye of providers. In addition to that, there's no standardization about what KDE actually is. And that can be a problem because it can create a fractured landscape of different types of educational materials, some of which could be very effective, but others that may not have any effectiveness at all, but they're being utilized in order to use the KDE benefit. And finally, there was a big question around who should be educated and then who's doing the educating. And so some other features is that CKD benefit excludes CKD stage 3 and 5. So not all CKD patients get educated through the CKD benefit, only certain ones do. And then in addition to that, not the entire sort of provider landscape can reimburse for it, only clinicians and nurses, but not facilities. There is one caveat, and that is that in the ETC model, CMS did propose at one point to include facilities in the CKD benefit, but recently that was withdrawn. So last year, Baxter conducted a survey of educators, nephrologists, and large and mid-sized dialysis facilities, trying to get more information and insight into how the KDE benefit is used. And here for the next 2 slides, I've drawn a couple of the more interesting takeaways from that survey. And the one that you're looking at here, this really sort of covers the most common reasons for this underutilized KDE benefit. And you see a laundry list of rationales in terms of how these different types of providers believe why it's being underutilized. But the one that really sticks out and is at the top of the list is that nephrologists are oftentimes sending patients for education to dialysis centers or other locations because they are focusing their time on other parts of patient care and education. And so that creates sort of a weird dichotomy where the KDE benefit is utilized only by clinicians and nurses, but then clinicians and nurses are oftentimes sending those patients to facilities to get the education, and thereby you're sort of undercutting the rationale for the KDE benefit. The other interesting takeaway is what types of information is being utilized here. So you see here 2 columns, one that shows commonly used KDE materials, the other one commonly used KDE sources. And what you really see here is a fragmented array of different types of educational materials being used. And so most common are pamphlets and brochures and booklets. And then the rest of it is mainly websites with a few people getting handouts and even a smaller group taking courses or classes that are going to educate them on their treatment options. And then on top of that, the most common sources are online sources. So what this ultimately entails is maybe providers going in and looking for materials online, doing web searches to try to pull information up that then they turn around and use to educate patients. But what you don't see is a sort of standard platform of education that's being used to render this KDE benefit. So I want to conclude today by reviewing some items that I think would fit into a framework for policymakers to understand both how to utilize shared decision making, but specifically how to utilize it through the kidney disease education benefit. So the framework consists of these 4 elements. First, ensure that there's adequate value for the service. This means potentially better reimbursement for the KDE benefit, but I think it goes beyond that. Lots of organizations in the CKD space have spent a lot of time and effort thinking through how to deliver education that really matters to patients. That educational pursuit has a lot of value. It has value for the patients individually. The better informed they are, the better that education is at ensuring that they retain the information so they can really be active in their care decisions is really important for them individually. But it's actually really important for the system writ large. An informed patient that makes the best decision for themselves is most likely going to be a less costly patient to the system. And so this is the type of thing that we really want both governments, but also organizations to think through what's the value of their educational tools and make sure that value is very, very much present in what they're doing in terms of delivering it to patients. Secondly, the information must have standards. And we saw it in a previous slide that there's sort of this fractured environment of information out there for patients to be educated. Organizations like AAKP are putting a lot of time and effort in thinking through what are the best ways to educate patients. And we really want policymakers to understand that, to maybe start to make decisions about what is and what is not education when it comes to reimbursing for the KDE benefit. Doing that would ensure that the information out there available to patients really is the best possible. information that is validated and tested and is proven to be effective versus information that simply you find on the internet through web searches and is handed off to patients and hope that they read it and educate themselves. We really want education techniques and tools to have that sort of standard set of values so they really can deliver something positive to patients. And the last two elements really have to do, again, with who gets educated and who is doing the educating. And then with this one, I think there's a guiding takeaway, and that is we really want to ensure that for both of those, that however the policymakers divide it up, that it ensures maximum exposure to the information. And so if you're talking about patients, right now just CKD4 patients can receive this CKD benefit, or the providers can receive it for educating them. It's worthwhile thinking about whether that should be expanded to CKD5, and maybe worthwhile thinking about how many other CKD patients should be exposed to this type of information under the right circumstances. And then beyond that, there's a big question about who should be doing the educating. And in here right now, as we said before, this is clinicians and nurses, but there is a bit of a disconnect there. You have clinicians and nurses doing some educating, but for a large part, that education is being delivered by facilities and by other educators. We want to make sure that those educators are also inclusive of this, particularly if they're the ones who are doing that type of work. The people who are out there doing the best education should be the one who are being incentivized to do more of it. So that's the framework that we want to make sure that policymakers understand. This is a conversation we want to continue to have with AAKP and other organizations, and we think that we can arrive at this type of framework in terms of our advocacy going forward. So with that, I want to thank you so much for your time today, and happy to take any questions.
Thank you, Chris. That was an excellent presentation.